Mr. Chairman, ladies and gentlemen, thank you. Sodium thiosulfate as otoprotectant to reduce the incidence of cisplatin-induced hearing loss. These are the final results of the SARPEL-6 trial for standard risk hepatoblastoma. This is my personal faculty disclosure. So SARPEL-6 sits very nicely in the SARPEL suite of clinical trials. Started in the 1990s with SARPEL-1, where all hepatoblastoma patients were treated, and then moving on with the prognostic factors that came out of SARPEL-1 and the pre-treatment extent of disease, being able to define standard risk from high-risk disease. Standard risk hepatoblastoma comprising pre-treatment extent of disease 1, 2, and 3, and no metastases. The SARPEL-3 study was a cardiotoxicity reduction study, and the SARPEL-6 study was an ototoxicity reduction study. SARPEL-3 was published by Giorgio Perilongo et al. In the New England Journal of Medicine in 2009. And the conclusion of this study was that cisplatin monotherapy alone was not inferior to the combination Play-Doh. The 3-year survival was excellent, but we were left with the serious issue of bilateral high-frequency permanent hearing loss. In the late 80s and published in 1991, we put out a grading system from Great Ormond Street Hospital in London, which became known as the Brock grading. And this was designed from 80 children's audiograms with high-frequency hearing loss. Grade 0 is considered adequate hearing, but from grade 1 onwards, young children have great difficulty in the acquisition of language. From grade 2 onwards, hearing aids are required, and grade 4, it is necessary to give them cochlear implants. None of these treatments give the child normal hearing. To understand how hearing loss in young children affects speech, this is the background audiogram with superimposed the speech frequencies, letters corresponding to phonemes. And if you can see in the right-hand corner here are the consonants. And it is these consonants that are crucial for language. And as we go through the Brock grading, the th is reduced, and then the F, oh, it's not, sorry, it doesn't appear to be moving on here. Oh yes, sorry. So we lose the th, and then with Brock grade 2, we lose the F and the S, the S, which is crucial for plural and for many words. It's the most used consonant in the English language. Brock grade 3, we lose the D, the T, and then Brock grade 4, we start losing the vowels. It was very exciting for me when in 2005, Christy Knight, the audiologist from Portland, Oregon, who works with Ed Newalt, discovered the Brock grading system, and I was invited over to Portland to look at the really fascinating preclinical work that they were doing there on sodium thiosulfate, a thiol which was shown to reduce cisplatin or carboplatin ototoxicity. And Nancy Doolittle published in 2001 an adult study where carboplatin was being given through blood-brain barrier disruption after high-dose mannitol, and carboplatin given in this way is just as toxic as cisplatin. What was very interesting to me was that the sodium thiosulfate was delayed by 2 hours, 4 hours, and later up to 8 hours, and it still was otoprotective. So I think you can see in adults, they are able to have a baseline hearing, and you can see the change in hearing. So this is hearing loss increasing through the cycles of carboplatin, but this is protected with delayed sodium thiosulfate. So this gave us the opportunity to think about using a drug in children with liver cancer. The challenge was, of course, that here there was a 2-compartment model where cisplatin was separated from the STS by space. And what we needed was to see how we could use this drug safely in children with liver cancer. Pat Reynolds and his team, and published by Harnett et al., was very helpful in doing cell studies and a very nice neuroblastoma xenograft model, where you can see here that they showed that if cisplatin is given at the same time as sodium thiosulfate, you get complete inhibition of tumor volume growth. This is tumor volume growth, and it is the same as if you were giving no treatment at all. However, if you give cisplatin alone, or if you give cisplatin with STS delayed to 6 hours, you get no impact of the STS on the tumor growth, and the cisplatin works. So this enabled us, together with Ed Newell's help and the SciPel team, to put together a trial that we felt was safe in children to assess the efficacy of delayed sodium thiosulfate in reducing the hearing impairment caused by cisplatin chemotherapy. There were a number of secondary objectives, particularly to look at the impact on survival, to look at the tolerability of the combination, and to evaluate prospectively various biological, radiological, and pathological features, also to look at cisplatin DNA adducts, and to collect patient DNA for looking at the predisposition genetic factors for cisplatin ototoxicity. The primary endpoint of this study was the rate of Brock grade equal to or more than 1 hearing loss, determined after the end of treatment and at least at the age of 3.5 years. This is because this was a multinational study and we needed to use a gold standard pure tone audiogram which can be compared multinationally, and children are only able to do this from the age of about 3.5. The trial was designed with an 80% power and a 5% significance level to detect an absolute reduction of 25% in the rate of Brock grade equal to or more than 1 hearing. From SciPel 2 and 3, we knew that the hearing loss was about 60%, and we wanted to reduce this by 25%, and this meant that we needed a sample size of 102. The secondary endpoints are event-free and overall survival. This is the schema. All children received a diagnostic biopsy, tumor and blood was stored, and the imaging was checked for standard risk disease. The children were randomized to either get 6 cycles of cisplatin alone or 6 cycles of cisplatin and STS. The cisplatin was given over 6 hours. In previous SciPel studies, it was given over 24 hours to try and reduce the ototoxicity. And because there was going to be a cisplatin alone arm, we didn't feel we could reduce it to less than 6 hours. Normally, if you're going to give STS, you would want to give the cisplatin over 1 hour to get all of your STS in within the 8-hour window. But we felt that that wasn't right at the time, and so we have a 6-hour cisplatin infusion followed by a 6-hour gap when the STS is then given over 15 minutes IV. The trial opened in December 2007. We hoped to run it over 2 or 3 years, but because of all the issues of countries being able to join us, there were 11 countries that did join, and I'm very grateful to them, but it took us longer to recruit, and we ended the recruitment in December 2014. This is the consort diagram. 116 patients were registered, 113 randomized. That gave us 53 in the cis alone arm and 60 in the cis plus STS arm. After certain exclusions, there were 52 evaluable in the intention to treat of the cisplatin arm and 57 in the cisplatin plus STS arm. These are the patient characteristics. You can see that these children are very young at diagnosis, a median age of 13 months. The AFP is typical for standard risk disease. Sex ratio is expected, and we stratified pretext 1 and 2 with pretext 3 because the prognostic outcome for children with pretext 1 and 2 is very similar. These are the acute adverse events, which are as expected: febrile neutropenia and infection, hypomagnesemia known to be caused by cisplatin, the hyponatremia by the high sodium load of the STS, and vomiting and nausea from both cisplatin and STS. These are the hearing results in percent of Brock grade equal to or more than 1 by treatment arm. So in the cisplatin arm, 67% of children actually had hearing loss, and this was reduced to 37% in the cis plus STS arm, giving us a p-value of 0.0033 and a relative risk of 0.56. If we look at the hearing results in percent by Brock grades by treatment arm, then we can see that Brock grade 0 is significantly different. There is also a slight reduction as the grades increase. The event-free and overall survival are similar in both arms. 6 children died on this trial, 2 in the cisplatin and STS arm, and 4 in the cisplatin alone arm. 1 of those children had pretext 3 disease, all the others had pretext 1 or 2. So there is no significant difference in outcome. So in conclusion, this is a randomized phase 3 trial of adding sodium thiosulfate to cisplatin treatment for standard risk hepatoblastoma, and it significantly reduces the incidence of cisplatin-induced hearing loss without any evidence of tumor protection. We have therefore gone on to launch a European named patient program for standard risk hepatoblastoma, and I think it is very, very important that in the interim before this drug is licensed, that children are getting a controlled pediatric formula with very clear instructions on dosing, antiemetics, and timing, because I would not want any child to be getting STS off the shelf for an indication for cyanide poisoning without clear instructions for the nursing staff as to how it should be given. The way to access this program, and the drug will be given for free, is through the email clinical@fenwickpharma.com. Regulations will be different according to your country. Thank you.